This video provides information and demonstration on the proper technique for pelvic proprioceptive neuromuscular facilitation. PNF of the pelvis can be a very valuable tool to help reestablish proper neuromuscular control of the lumbopelvic region during functional activities such as gait. To properly perform any PNF pattern, it's important you pay attention to your manual contacts, verbal cues, and the precise pattern of movement you're eliciting. So let's start by reviewing the proper patient position for pelvic PNF. For pelvic PNF, your patient should be positioned in side lying with the involved side up. The spine and pelvis should be positioned in neutral and the hips and knees are flexed. Similar to scapular PNF, we have 4 directions of movement: anterior elevation, posterior elevation, anterior depression, and posterior depression. With pelvic PNF, it's extremely important to understand that these movements are linear movements and do not contain any components of anterior and posterior tilting. To help both the clinician and the patient visualize the patterns of movement, you can use a clock face as a reference. Pelvic linear movement moves along 2 lines located between 5 and 11 and between 7 and 1 on the clock face. Be sure to use the appropriate reference point depending on which side is being treated. Let's start with posterior elevation. The motion that is occurring is a superior and posterior translation without a component of tilting. The muscles responsible for this motion are our ipsilateral quadratus lumborum, ipsilateral latissimus dorsi, iliocostalis lumborum, and longissimus thoracis. For this direction, the clinician is positioned behind the patient. The heel of one hand is placed on the crest of the ilium, just posterior to the midline. The other hand lays on top of the first, and the clinician makes sure to orient themselves in the line of direction of movement. The goal of our hand position is to provide tactile cues as to which direction we desire the patient to move. Sample verbal commands include push your pelvis up and back or press up into my hand.
Right here, cue up, pull, there you go. Up into my hand, nice. Press up into my hand, up into my hand. One more time, up into my hand. Good.
One of the more challenging directions for patients to perform is anterior depression. With this pattern, the pelvis moves down and anteriorly, again without tilting. To complete this motion requires contraction of the contralateral internal and external oblique muscles. With both anterior and posterior depression, the amount of movement is relatively small. For this pattern, the clinician can be positioned either in front of or behind the patient. Manual contact can be placed either at the anterior inferior greater trochanter or on the anterior inferior iliac spine. The second hand then can reinforce the position of the first. Remember, the goal for manual contact is to facilitate the proper movement. If one location is ineffective, try considering the alternate. Verbal command should direct the patient to move the pelvis anteriorly and inferiorly in a linear fashion.
Right. Press down into my hands. Down into my hands. So you're relaxed. So think of it like a rocking. There you go. Press down into my hands. Down into my hands. Down into my hands.
The third of our 4 patterns for the pelvis is anterior elevation. Our desired motion with this pattern is to have the pelvis move anteriorly and superiorly. A mistake patients commonly make when trying to perform this pattern is to do a posterior pelvic tilt. It may be helpful to move the patient passively before attempting this pattern to make sure they understand the motion. Our patient is positioned in side lying, and the clinician is located behind the patient. For anterior elevation, our point of contact is on the crest of the ilium, just anterior to the midline. The second hand then overlaps the first. Verbal commands should be used to encourage the patient to elevate their pelvis up and forward. If the patient continues pelvic tilting, you can try the command pull your pelvis into your rib cage.
Pull up in my hand. Pull up into 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 my hand. Up into my hand. One more time. Up into my hand.
Our final pattern is posterior depression. With this pattern, our pelvis moves down and posteriorly, again without tilting. The muscles involved include the contralateral quadratus lumborum, iliocostalis lumborum, and longissimus thoracis. Similar to anterior depression, our posterior depression motion is fairly small and difficult to isolate. The clinician is positioned behind the patient. The manual contact includes the heel of one hand placed on the ischial tuberosity. The clinician's second hand is then placed overlapping the first. Effective verbal commands for this pattern include sit into my hand or push down and back into my hand. As mentioned previously, it's important that the clinician is positioned and aligned with the direction of the motion that is desired.
All right, sit into my hand. Sit into my hand. Sit into my hand. Sit into my hand. Good. Sit into my hand.
So to review, the 4 directions for our pelvic PNF patterns include anterior elevation, posterior elevation, anterior depression, and posterior depression. For most patients, including those with neurological deficits, isolating these motions can be quite difficult. So be sure to take some time and teach the patient the pattern before you move on to full PNF training.